All right. Hello, everyone. Thank you so much for joining us. My name is Chantel Thompson. I'm the Director of Diversity, Equity, and Inclusion here at Child and Family Services. And we are excited to have you here today for our Women's History Month event presented by the Diversity, Equity, and Inclusion Committee. We're really excited to talk today. We have Kirsten Newby here from Child and Family Services. She is a health home supervisor, along with folks from Community Health Center of Buffalo. We have Megan Quinn, who's the Behavioral Health Department Manager, and joining us in just a second will be Dr. Kenyani Davis, who is a physician over at Community Health Center of Buffalo. So we're really excited to jump in and talk about health homes as it relates to the social determinants of health. And so with that quick introduction, I'm honored to pass this over to Kirby.
Thank you so much, Chantel. It is a pleasure for me to be here with you, Megan. It's nice to see you again, and Dr. Davis will be joining us momentarily. I don't really want to get too far into the questions without her being present, but I just want to say that, the social determinants impact health in so many ways. And so I think it's important, and I'm glad that we could all come together in this forum to just have a brief discussion about what we do as individual organizations and what we can do together to try to affect some of the health outcomes of our respective populations. Hi, Dr. Davis.
Hi, how are you? Sorry I was late. We're actually running a vaccination clinic simultaneously. So if all things could not be smooth today, today's that day.
Yeah, Murphy's Law is definitely effect over here at Child and Family too. So don't feel
okay,
bad.
so it is here.
So I was just telling Megan, thank you so much for taking the time to do this with us. We really appreciate it, as it is Women's History Month. And, we have a very specific population that we're all trying to help. I think it's really important to be able to have these discussions so that we can see, what's going on in our community and how to best help each other. And so one of the questions that I'd like to start with, Megan or Dr. Davis, whichever one of you really wants to answer. But a lot of people hear the term social determinants and they really don't have a good feel for what that means and how it relates to medicine. Can you talk about what are some of the most significant social determinants in our region?
Yeah, thank you for that question. And once again, I apologize for being late. Social determinants of health is a very, very important topic, because social determinants of health, when you look at the total pie of somebody's health, 80% of somebody's health is related to their social determinants of health. The other 20% is based off of the 10%, which is genetics. The other 10% is what I do with my stethoscope Monday through Friday. So you can see a large part of somebody's totality of their health is actually due to social determinants of health. So what that means is when people say, oh, we want to improve people's health, they're so quick to talk about things like access to insurance. But the truth is that access to insurance gets them to me, which I only affect 10%. So what about that other 80%? And those 80%, when you look at, there's different frameworks of looking at social determinants of health. But if you look at, I usually use Healthy People 2020's framework, which is 5 different particular social determinants of health. These are things like healthcare and access. This is community and context, economic stability, built environments and neighborhoods. And underneath there's different things like housing, childcare, right? Safety for built environments, criminal justice, injustice. All of these different things contribute to 80% of somebody's health. So that is the reason why it is so important to have this conversation mirrored when you start to talk about people's total health.
And when it comes to behavioral health, a lot of the times behavioral health is working side by side with our medical providers, which is very, very important. We like to focus on our no-show rate. We do have a high no-show rate, and that typically is because of the social determinants of health. So, with behavioral health care coordinators kind of reaching out to our patient and our community, a lot of the times they're not making it to see their PCPs and getting their medical care because things like transportation, it's their housing, they don't have food. If you really think about it, someone who doesn't have anywhere to live, which are they focusing on at that point? Getting to see their PCP or finding shelter? So it's really, really important to kind of work side by side with the medical providers.
Thank you, Megan. And that's absolutely true. Something that we on the health home side see all the time as a barrier to be able to provide the total package of the care that we like to wrap around the families. You have to be able to impact those things that they're worried about on their everyday life. Certainly if food and keeping your lights on and where you and your children are going to lay your head are an issue, then certainly they're not going to be interested in any little goals that you have for them because they're worried about their day-to-day living. So thank you for that. And so my next question really was going to be, how do the social determinants affect your own methodology in treating your patients, which you both kind of alluded to? So can you speak a little bit about those patients? You or someone have elicited a history and you know that they are fully impacted by all of those things. They don't have a good housing situation. They have health literacy issues. How do you then incorporate those needs into the goals that you have for their health?
Yeah, I think that's a good question. I'm going to take that question in a few different parts, right?
Okay.
So I'm gonna find a way to give you an honest answer, a diplomatic answer, and a hopeful answer at some point. But the truth is the notion about social determinants of health, I think that it's been it's very robust in particular genres. So like in Megan's world with behavioral health, we talk a lot about social determinants of health. In your world, you talk a lot about social determinants of health. However, for medicine, right, it's a new terminology, right? Even though it's been persistent. And anything that's new in medicine takes about 10 years to truly diffuse into clinical practice. And so I want to keep that in mind, because not every physician approaches social determinants of health or even understands social determinants of health. So it may not be factored into their work, if that makes any sense, which is a big downfall when you're talking about vulnerable populations or populations that are heavily afflicted with social determinants of health. With that said, though, here's the hope part, right? That we are introducing it to our medical students a lot more. We are introducing it into the medical literature and as well as health disparities. And it's so important so that we can start to try to factor that into our care just as much as we factor into the hemoglobin A1C, right? Because the truth is when you look at, let's take a diabetic and we measure it based off of the hemoglobin A1C. I know that more than 1/3 of the patients who have a hemoglobin A1C greater than 9%, which is actually really high, suffer from food insecurities. So that is a social determinant of health that drives what I do every day. So it's so important to understand how the two have the symbiotic relationship and how they play a part. But for me, it's knowing those little things. So when I start to see things that are out of control, I see a diabetic who was once controlled, who's not controlled anymore. Now it warrants a different conversation. So what's going on, bud? Like, are you able to afford the medications? And it's all in how you say it, right? Because sometimes if you ask somebody, can you afford the medication? That can be offensive sometimes, right? So it's all in how you word it, but to start to explore those different social determinants of health in those 5 different categories to see if any of it's relating to what I'm physically seeing from a health perspective. And that's how I use it personally to render treatment plans for my patients.
That sounds amazing. That makes the goals that you have for your patients much more realistic when you know the barriers that they're facing. Megan, is there anything particular that's done on the behavioral side when they come in, when you know that they have those social determinants that are affecting their decision making? Because, in light of the pandemic, on top of that, I'm sure you are seeing a vast increase in the type of complaints, the level of anxiety and depression, all of that is going up. People are fearful. You just don't know what you don't know. How are you and your team impacting that coupled with the social determinants?
I guess most of the time, when you're paired with change that a medical provider is asking for, it comes with anxiety. We have a lot of patients coming with anxiety. My PCP is asking me to do this, 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 and this. How am I supposed to do this? I can't even do one of the 6 things that they just asked me. So there's a lot of, yes, you don't mean to. That's
not my intention.
But that's, your piece in this. And then it's behavioral health piece to take each case individually, meet them where they're at, and then get them linked with the resources that are necessary. Providers are given 15 minutes to see patients. They don't have all that time to explain, okay, go here for this, go here for that, go here for this. We have the time to sit with them, weekly to work with them, to work with their families, to work with the community, to link them with the proper services that they need to make, to improve their health outcomes.
Okay. And so then I see that both of you guys are all over it, and we love that. What do you feel are some of the reasons that providers in general, understanding that social determinants is a buzzword, it's becoming much more mainstream, but what do you think is the general uncomfortable feeling that comes with addressing those needs when we know there is enough literature, we're learning enough to know we see it? There is a direct correlation between making medical decisions and those social determinants. And so many providers, it's just taboo. For example, I'll give you a really quick example. So I was doing a case review just last night, and I was really, really impressed. They asked all those social determinant questions. And the very next question on their sheet was, did you make any community referrals? And the answer was no. And I'm like, you have identified, you took the steps to put this into practice, but then nothing. So what do you think is the barrier to providers, being willing to have the conversation and then do something?
Yeah, what's funny is, I get this question a lot, right? And because I have dual roles, right, I can understand, but as a provider, let's say I just put my provider hat on, right? Where do you want me to send them? There's about 50 different places. And if they're physically not in my face right there, or I can't do a warm handoff to somebody else, I don't know where to go with this, right? And it's not an excuse, right? But I think that is the number one issue that you're going to have with providers with referring for social determinants of health. Not that they don't believe in it, not that they're not going to take the time to address it, but the next thing is I don't know where to go with it. So we have health homes that have these qualifications, and then I got to call a number, and then I got to put in a referral. When do you want me to do that? I got about 22 patients on my panel and about 50 tasks left for the day. And at some point I have to pee. So
no, Dr. Davis, why do you have to do that?
And eat.
I gotta pee and I gotta eat. So I mean, all jokes aside, I think that's where the missing link is. And every physician, no matter where you talk to, in a federally qualified health center or in the suburbs, they'll tell you, if you put them in my office, I will give you the patients, right? They just physically have to be there, because the way the medical model works is not conducive yet to all of this type of innovation, right? So part of the thing is moving medicine into a more population health focused, which means that you need more than just the physician there. And the physician is not necessarily the driver of the totality of the care, right? And I think I'm probably going to get my white coat revoked for saying that, right? But it is the truth. When you're really dealing with a population with heavy social determinants of health, I am not the driver. I am the supporting cast member, right? And I think that's a very important thing to understand. The other thing is, from not making that link as well, I have a magical unicorn called Megan that I can call, right, at any beck and hour or time to help me with this. Keep in mind, not every place has that ability. And then I always say, if you really want to drive that type of change, you have to go ask those payers, give me an ICD-10 code for a Megan so that I can support and pay their salaries, because the work that they do is really what's going to get my hemoglobin A1C down. So, so there's many different structures that play on each other that creates that Swiss cheese model. And I would say that is the number one reason why, in that case that you're talking about, why that linkage probably didn't occur.
And that makes really good sense. And I think that even from my provider hat, when I was wearing that hat, it's different for a PA, because that's our goal, to sit, talk, teach, and help find resources. But now that you put it in the words from your mouth to my ears, what you're saying does make perfect sense, because even in the HMO model, and I'm dating myself in age, when they first came out, I had a doctor tell me, you know what, you are really sick, but I only get 7 minutes. So you're going to have to come back every day for me to address those problems. And so looking at it strictly from a provider lens, and I think it's important for our constituents and our public and our friends and everyone who's on this in this meeting to hear directly from a provider. It's not that I'm not willing, but I don't necessarily, just like you're missing resources that you need, I don't have any available resources. And for me, there's one of me, it has to be grab and go, so to speak. So I'm thank you so much for making that point. I think that will enlighten a lot of ways that people look at social determinants and why they're not getting the help they need. And it's just going to bring me to a later point about, you know, we all have to be educated in what's out there so that we can better inform the system. Megan, did you have anything that you wanted to say about that? Or do you think Dr. Davis stole your shine and said how wonderful you are?
I could never steal Megan's shine. Like, Megan is being proof.
I know, I'm trying to figure out where I'm going to get a Megan from.
Listen, you need a Megan.
I need a Megan.
You know, Dr. Davis took the words right out of my mouth. I was thinking about the entire time is we are actually very blessed at CHCB to have such a camaraderie between medical and behavioral health that we can take the time. We have social workers, we have care coordinators, we have community health workers that really do all of the research, all the collaboration behind the scenes and getting all the players that we need here to the table so we can better serve our community and our patients because we have more time. We're working, you know, together all the time of, you know, here's your 50 minutes to work with the patient, then drop them off to us. And we're right in the building. We're literally down the hallway. They can yell my name and I'll come running. So we're really blessed in this facility, but I know every facility does not have that. They don't have the integration of behavioral health with medical.
Yes, for sure. And it's something that hopefully, as this gets out, our wonderful recording, and they see how great your system is, and you know that there are things such as health homes and child and family services. It has a whole another basket and array of services can help that they will strive to model after our platform. So let's just talk a little bit about women's health specifically. We know that heart disease and cancer and diabetes, those remain at the forefront for the leading causes of death, especially in the African American population. I believe the last time I looked it up, it was circa 23, 22, and 5% respectively of how it affects us. What do you two, either individually or as an organization of community health, do to assess the health literacy? Because a lot of times in just dealing with their parents, it's not that they're not willing and they're nodding and their body language is appropriate. And you don't find out until later on when you build more rapport that they didn't understand what you were asking them to do from the very beginning. And you thought they did, and you incorporated your goals and your plans that way. So how do you guys target the problems and the inequities that come with poor health literacy?
Yeah, it's a loaded question. No.
Dr. Davis, I just like the way you unpack it in layers. So that's why I was
parts. Just throw it in there, right? I think, you know, the first part, the uniqueness of CHCB is that we employ the community, right? So you don't get a chance to really put on the facade, right? So I think if I go back to kind of my notion about having representation at all levels of healthcare, what happens is the patient feels that experience, right? So they don't feel that they have to pretend to know when they don't know, right? For my patients in particular, right? I know what questions to ask because guess what? I've been there, right? So I wasn't always born a physician. So that type of transparency is so important because when you don't have the health literacy, it allows the providers to be able to break it down at a level that you do understand. And I tell people all the time, when it comes to health literacy is not something that you obtain just because you have an education. You can have all the PhDs in the world, but not have real good health literacy. Health literacy is something that it took me 20 plus years to try to figure out some part of health literacy. So it's not factual or real for me to think that my patient is going to understand it in the same way just because they did a Google search, right? Even though some of them do think that just because they did a Google search and read something on Facebook that we got the same degrees. But The truth is that identifying somebody's health literacy at the very start. And the number one thing to do with that is a teach back, right? I gotta hear it in your own words. And that's one of the things that all of our providers here do, is we need to understand where you're at first. And that's the first and foremost from the health literacy part of it. And what I want to add on there is, because you mentioned African-American women, right?
Mhm.
The Black female experience is very unique. So I'm very careful to not throw it into this homogenous group, because there is a thing, there's a thing called weathering, right? It's a theory, right? It's a theory that deals with what we call allostatic load. And what that is, means that all of the stressors that you take on actually physically change your DNA, that actually produce disease at earlier onset. So the Black female experience is a little different, and it's very unique, and it's definitely something that I do a lot of talks on. So it's definitely that population, especially when you talk about family and children's services, right? That experience is very, very unique in that regard. And so we always keep that in the forefront, especially for our pediatric patients as well.
That was such a good answer, Dr.
Another loaded answer for a loaded question.
Yeah, but very well explained. I can't say when health literacy became very evident to providers and anyone in human services as a whole, but it is now definitely something that everyone is starting to look at, and I'm so glad for that. And Megan, I hope I didn't cut you off, but what I wanted to add on to what Dr. Davis said is the approach that you have is wonderful. And I think that for anyone in our audience who is also a provider or human service worker, it's about setting that mindset from the very beginning. Okay, because I find that when I'm meeting someone new, that rapport building, that building of trust, and it's okay to say, ask me anything, and genuinely mean it. I think that when people are coming to see us, they have already formed conclusion. Oh, that's Dr. Davis. Oh, that's Megan. She's had her behavior. Oh, that's Kirsten. She's the manager to the person that I saw. So, I'm going to take a position like I know what's going on, and I go in a subservient role. I am here to help you. I'm here to be that bridge. Let's chat and chew it. Let's talk about it. There's nothing too simple or nothing too complicated. And ask and ask and ask. And I think when a provider says that, and they see it from you, like I felt everything that Dr. Davis was saying. I felt it, I embraced it. It was very genuine. And so, if I were her patient, then I would believe that I could speak to her about anything. And I think that is at least a third of the battle, them knowing that they can come to you with those questions and not be judged, and get the answers that they need to help make them, to help make better decisions. So go ahead, Megan, you can say whatever you want to say about that.
So with my perspective on this is that I tell patients this all day, every day. You are the expert of your own life. I am not the expert. I'm going to meet you on your level where you're at, and how it is that you need for me to help you, or questions that you need to ask, and answers. If I don't have them, I will find them for you. A lot of, situations that we come into is they're hearing what the provider is saying. They don't know what that means, though. They don't know how to act. They don't know what the next step is. That's where, care coordination comes in, behavioral health comes in, providers come in, is we can give them information. It doesn't mean they know what to do with it. Where do I go? How do I get there? Because that's a big one. PCPs are sending, individuals to specialists. So we get a bunch of referrals, and they are like, okay, that's fine. How do I get there? I don't have a car. I can't get there on my own. I need help. And it's kind of using our powers to help them get that transportation set in motion. Here's the next step. Here's what I got you to do. Here's your referral. And, just piggybacking off, I think what the providers are doing is just, saying again and providing the information. And for what answers that, aren't out there, we'll find them. There will be an answer, and we'll help out with that.
Wonderful. So when I was looking at some stats recently, and it came out that about 4.2 million households are comprised of just women and children, which of course, is my respective target population. And so I'm curious as to how we can best help each other as you continue to focus on women's behavioral and physical health initiatives to also impact the outcomes of the children of the women that you're serving, targeting those very specific areas that seem to plague the whole population, which is keeping up with their well visits. The no-show rates just across the board are just very high. Dental care, the preventative care that comes, seeing the dentist twice a year, getting that baseline cleaning. Asthma, making sure that the kids have an asthma action plan in the school, that everybody knows what to do, that they have those rescue inhalers. And then obesity, both of you kind of spoke very eloquent about the tools. We say, this is what we want you to do, but no one is there to say, these are the tools that you need to get there, which is why the way that you have your practice set up is wonderful. The way health homes are designed is wonderful. And so I just want to know, as you guys are targeting women, how do we help the children of those women? How do we work together so that you get better health outcomes, and then we can impact the health outcomes of the children of your population?
Yeah, I would say, from, once again, two-part answers. As the chief medical officer, I think my job is to ensure that we have a comprehensive system that has coordinated care, so that when those women do come in, they can come in with their children, right? And they can get it all done in one fell swoop, right? So if you only got one day off, right? Let's get everybody done in one day, right? We have women's health, we have family planning here. So if you need your pap smears, your mammograms, we got that person. We got PCPs, you need your annual physical exam, we got that there. Your dental exam, we got that for you and your kids here, right? The counseling service, we got that here. You need care coordination, you're having issues with childcare and stuff like that, we got that here. You need insurance, we got insurance enrollers here. So we try to make sure that we look at our population and we pivot based off of our population, not based off of what we think they should do, but based off of the needs of the population. So for instance, this little thing called coronavirus came, just a little thing, shut the schools down, right? We actually employ, I told you, we employ the community. A lot of them happen to be single mothers who have kids who are in schools. Where are they supposed to go now, right? What are they supposed to do, right? So our CEO said, hey, and when our CEO has an idea, it makes everybody love her to pieces. And I'm so sorry she could not be here today. She was feeling a little under the weather because she got her vaccine and she wanted to be here. So I just wanted to throw that out. But we actually hired a teacher and put a pseudo school inside of our building on the 4th floor. We shut everybody's break room down and turned it into a school. So we met the needs of our particular community. So from a CMO role, that is one of our things. As a provider, I tell people I'm pretty comfortable and confident in my diagnostic skills. I can diagnose you in about 5 minutes if you ask all the right questions, right? The rest of that time is for me to understand who you are, your family dynamics, and what you have. And majority, if you come and see me, all we do is talk about your life. The last 5 minutes is based off of whatever the world you came in here for, right? Because that's important, because I get a chance to understand the dynamics of people's children. Sometimes we think that people have good relationships, but sometimes they really don't. Sometimes the stressor is actually the child itself, right? But that's very important. The other thing, on a personal level, I was a single mother, right? So it's very, very important for me to be transparent about my journey, because if there is any other single mother who walks into my office that I can inspire and let them know, oh, no. I had a 2-year-old by the time, I had a 2-year-old by the time I applied, graduated from undergraduate, right? I was pregnant at 19, right? I was a single. I can teach you how to get on the bus. You need that EBT card? I can teach you how to fill the form out, right? So it's very important for them to see themselves in my story as well. And so that is very important to me. And it's also important when they do bring their children, for me to see something in their children, to plant those seeds as well, right? To ensure that they have generational success. And so those are probably the 3 tiers on how I approach that particular question that you posed.
Okay, Megan?
I would say we're working with women and children, and especially the collaborations that we have with health homes is extremely important. When health homes was introduced to me, I thought that God saved us all because it really did. Because, we keep talking about care coordination and our social workers that we have here. And, there's just always can be needed efforts by external agencies and the collaboration and to stop working as silos and start working together as a community for the same mission. We all have one mission, and it's to help our communities. And I feel as if that I really leaned on health homes that we have worked with collaboratively to help the women and children get to their medical appointments, to help with education on, certain diseases that either, a woman has or a child has. I had an individual, single mother come to me with a child with pretty severe diabetes. And, the case was so complex, I knew I couldn't do it by myself. So that's when you start calling on, community organizations that are better experts than we are and utilizing those resources and working together as a team to tackle those barriers that these families face. And especially because when it comes to women and children, it's a family. It's a family that you have to, there's, millions of different issues going on that you can't tackle just by yourself. That, if there's something wrong with the child, there's, something's going on with the mother, the siblings, there's so many parts to it that need community resources to help with.
Very true. Okay, so I'd like to ask about data, just because we know that data drives initiatives that we're trying to push. And so because we know that process and policy change are driven by the data, how do you collect the data at a local or regional level? Do you use data analysis within your demographic to make decisions? How do you know then that your initiatives are working and that they are resulting in better outcomes? And if you're not able to track the data, then what is the primary factor that you use to support the wonderful processes that you all have put in place for your population and geared towards the social determinants?
Oh, data. So, you know what? Sometimes I like to call data disruptive innovation sometimes, right? So let me tell you why I mean disruptive. I think that I approach everything, especially when it deals with health disparities, vulnerable populations, or anything, in twofold. You have quantitative and you have qualitative, right? Because everything is so complex sometimes that you cannot put it in a box. Data is what you put in a box, right? So it's unfortunately all 18 patients of mine for the day do not fit in boxes, right? So I think it is very important to not just look at things as people as just data points, but we do allow the data to drive what it is that we're doing, because a lot of times if you have interventions and the data is not supporting it, then you really need to take a second look, right? A second look and say, okay, this isn't really going as expected. A, what needs to change? Two, am I measuring the right thing? And that's the other thing about data, is you have to ensure that your data point is measuring the actual thing that it's set out to measure, right? So let's take, for instance, one of our data points about childhood wellness exams, right? We're looking at it and we're like, man, we're doing a crappy job, right? Because they're not, we're not scheduling them, the no-show, so should we just do away with, that measure and that? Okay, well, maybe we need the qualitative part about it, right? Let's take the deeper dive with the social determinants of health. How many of these children are from single parent homes? How many of these people have access to cars? So data is a good starting point, but it's not the end all be all point. But we do use data to help drive some of our initiatives, but we're also very cautious to ensure that the data point measures exactly what it is. Also, when you talk about a population, the data sometimes comes from insurance companies. When they come from insurance company, there's a lag time. It's usually a 2 or 3 month lag time. The average person stays within an insurer for about 2 years. So you have all these different points that you're getting data from that may not be your most up-to-date and accurate ones. So a lot of times we fill in the gap by collecting our own data, but I think it's very important to not get so focused on the data, right, that you forget that it's a population that has real lives, real things that don't really give a damn about your data points.
Mhm.
Granted, and I will give you that all day. You are absolutely right. They don't care about data, but we know that data is what helps the people outside of us make
Absolutely.
those decisions about, it's the trickle down theory. So you show me the data, then I'll give you a packet of funds for this and a packet of funds for that. And so,
Exactly.
In this conversation, anyone who's a part of it can see that, the community health center, they are all about taking care of their population and incorporating social determinants, as is, child and family. Those are factors that we look at. But now, we together want to affect the larger pool, and we want providers across the board to be thinking about these. And so we know who we are as stakeholders, we know what the population is, but how do we together, separately, recommendations, how do people get the information out to those drivers that can trickle down some of the things that we need to continue the good work that we're doing individually, that we're doing together? What does that initiative look like? What does that movement look like? Even if we could take baby steps, what would the first step that the population who's listening to us, what can they do to start getting some of the things they need? And what can we do, and what can we do together?
Yeah, I would say the thing is you keep asking the question why until you can't ask it anymore, right?
Mm-hmm.
For my, the example I gave, why didn't those kids get there? Okay. Why don't they have a car? Why don't they? And then eventually you'll get to a point where you're like, aha, there's the intervention, right? But you're right. Data is how we communicate to other people. So it's important to speak the same jargon, right? And you can keep data points. The thing is finding a data point, right? That, like I said, measures what it's supposed to measure, that you can do something actionable with, right? A lot of times I sit in meetings and I hear all these data points. I'm like, oh, that's great. Can't do nothing with it. It's just data fatigue now, right? So being very purposeful about what you collect, because the patients can get data fatigue as well, right? We do, each one of us do surveys, right? So what do you do with those surveys? Or do we just collect them just because, the people who give us money want us to collect the survey?
Very true.
Right?
Very true.
So data fatigue is real. So I think just ensuring that collectively, whatever that data point is that we're doing, that it measures what we need to measure, and it is definitely something that you can create an intervention towards.
Agreed. And speaking of surveys, the population really, they do not want one more survey. They are surveyed out. You say survey negative.
Right.
Yeah, they definitely don't want any parts of that. So talking to our listeners, if you had one takeaway to leave the audience with, and it can be regarding health, social determinants, and the benefits of care coordination, what would it be? What is it that you want our listeners to have really learned from this conversation about healthcare, our population, care coordination, how great you guys are, because it seems to be all inclusive.
We got this.
You guys have it.
Not today. Not today.
You guys have it. Child and Family has been here for over 100 years. We have the good footprint. But what do we want our listeners to walk away with? What's the learning point for them?
What would you say? You're more articulate.
Try to be. One takeaway I really think is that, we are all here to work for our community. We have, like I said earlier, we have one mission. We all pretty much have the same mission in this area, and I'm sure across the country, is that we are here to help our community to do whatever we can to improve their well-being, their health, their happiness. We are always there to be helpful. And that, I would say, is a big takeaway that I would like the audience to have, is that, we can help them in any way possible.
Yeah. I would say that healthcare is complicated and it's complex. And one person isn't the star of that show. We all have to play our roles, but we have to play our roles simultaneously, right? And we have to play them together. Sometimes me as a physician, sometimes I'm the coach. Sometimes the patient's the coach, right? But we all have to, when our name is called, we all have to step up step up to the plate. And I think that's the takeaway that I want from this, is that sometimes it's not what it looks like, right? Sometimes there's a lot more to it. And we all have to play our role, and we have to play our role well every day.
Very well said, ladies. Thank you so much. And I would just like to say to the listening audience, if I were going to ask myself the question, I think the takeaway is that just like anybody else in your life, providers aside, communication is the key. Your providers don't know what they don't know. I don't know what I don't know. Do not be afraid to advocate for yourself and to ask the question. And if the person that you're dealing with or the entity that you're dealing with is not answering in a way that you understand it, there is no harm in saying, I don't understand what you're saying. And if you're not getting what you need, it is okay to advocate for yourself until you get the things that you need for yourself and your family.
Absolutely.
So that's it. Chantel's back.
I'm back. Thank you all so much. This was so amazing. I was actually just emailing my colleague while you all were talking. I'm like, are you listening to this? This is so good. Yeah, you ladies, I'm so grateful for this conversation. I have like pages of notes with all of these awesome quotes and insights and things for me to take back and think on in my role as Director of Diversity. There's so many equity related things here. Social determinants of health certainly play into health equity. So I'm really inspired and honored to have you ladies lead in this conversation. I know it's going to be very beneficial to our listening audience. We do have some questions, and I want to encourage the audience. We do have time for additional questions and comments. Before I look at the audience questions, I do have a question of my own. Dr. Davis, you were talking about the Black female health experience being unique, and you mentioned a particular theory, and I did not catch that, the theory in regards to stressors that produce disease. Can you repeat that?
Yeah, so it's weathering hypothesis, and it's actually done by Professor Geronimus. Very interesting work. She's out of the University of Michigan, and I believe she has appointments in UCLA as well. But it's the theory of basically all of these health disparities were present, and they could not be explained. And so she said, you know what, there's got to be something additional to this. It has to do with stress. There's got to be something with stress. And so really the hypothesis basically says that all of the wear and tear caused by stress actually causes the DNA to accelerate by 7.5 years. So African-American women's DNA is 7.5 years older than their counterparts, which are Caucasian. And the reason why that's important is because, so in research, we do things in parallel. So then there's another thing called allostatic load, which literally does the bench research part of it, which actually took that hypothesis and actually showed the physiological response to it. And when you have an allostatic load at about 3 or 4, you start to produce disease outcome, right? And so that is very pronounced in our young African-American females. So we're talking about in their 20s and 30s. And so when you see women in their 20s and 30s with things like hypertension and diabetes, why is that important? Because those are your childbearing age, right? So junk in is junk out in research, right? So we have African-American women who have higher allostatic loads, which lead to higher disease burden, which we also have bad infant mortality rates. We also have high maternal mortality rates. So you have to start to put all of these different things together. When we talk about social determinants of health, we talk about Black single mothers, right? Black men, the incarceration rate for 18 to 30 is super high, right? So now let's look at Black women, 18 to 30 single mothers. So it's complicated, it's complex. So that hypothesis is the weathering hypothesis.
Oh. Wow, I can't wait to dig into that a little bit more. Thank you so much for sharing that. That's a new term for me. We do have a couple of questions in the chat, in the comment box. So we have a comment here from John Rogers. He says, thank you for these insights. I'm the Chief Operating Officer at Independent Health. If you had a magic wand, what would you want to put on the top of my to-do list? That is an awesome question.
Thank you for that question. Are you ready? You got that pen? So
let me pull out my notebook.
You ready? So the magic thing that I would like Independent Health or any insurance company to do is to ask themselves, what are they doing about health equity? sometimes policy is the biggest driver of health inequities. And I need somebody in every boardroom to ask themselves, what is this doing to the disparity? No matter, I don't care if it's a finance question. You guys are talking about your strategic financial plan. So, I wonder what this strategic financial plan is doing to disparities, right? And I promise you can find a way to impact change. And maybe that change is, I only got 2 Black people working here. Maybe I need to diversify my thought process, right? So that is my magic wand that I'm gonna send out there.
I love that. I love that. Yes, diversity. Okay, we have a question from Ayana in the chat. She says, how do you, as medical providers, address indications of medical trauma, e.g. poor attendance and adherence to treatment recommendations, lack of trust, impact of historical discrimination, and empower patients to see knowing and understanding their health, both the good and the bad, as a strength? I believe that the stigma around mental health is slowly subsiding, and the coordination of mental and physical health care is one step towards this. But there continues to be a lag amongst those with higher risk social determinants of health. Just curious as to how the medical field is approaching this. Thanks.
I send mine to Megan. I send mine to the magical unicorn.
That's me.
That's me.
Yeah. I really think that it's important to, because it's very right on the mental health stigma. There is a strong stigma against mental health and myths and understanding behind mental health, and we run into it every day. And I really think it starts with the medical providers, which I think is so helpful of them introducing that discussion to them, is starting that first conversation piece of, hey, it looks like you are going through a lot, and you know, some of the health issues that you're going through, you know, I can help you with, but some of the underlying issues that are stemming these medical conditions are coming from behavioral health, mental health conditions. So I really feel that it's opening up the conversation that is very important in the medical field. I've been at CHCB for going on 6 years, and just how much it has changed in our facility, I'm sure, you know, around the area and other facilities, of it being talked about more. It's not, you know, being ignored. It's not shoved in the back. It's something that's on top of the focus of even the medical providers seeing each patient. What's the first thing you do? Give the PHQ-9 on depression. It's the very first thing the MAs do when they're in the pods with the medical providers, which I think is very important. It's integrating the two as one.
That is great. Thank you for that answer, Megan. Thank you, Ayana, for that question. That was a really great question. We have a comment and question from Kiana. She says, this is a great conversation. It's great to hear that the community center has the great resources for the community. How do you incorporate the knowledge that you have into our local hospitals, ER, and even to some of the people you employ, i.e. admin staff?
Yeah, that's a good question. So I think one of the things is everybody here at the health center has these joint appointments in this 1 foot here and 1 foot there. So I'm actually still a part of UB. So I'm still actually a faculty member at UB. I'm also the director for employee health at UB. So I take care of all 900 residents and fellows that are there. So I'm still heavily ingrained into education. And for the reasons that I said, that vertical representation is so important. And so that is my way on the education arm to continue to diffuse this particular knowledge. I also have an appointment with the School of Public Health for Community Health and Health Behaviors, and teach a social determinants health class there. So that's my role. Megan has appointments also in her foot in the door there. Our CEO has her foot in different places as well. So it's very important for us to kind of have these tentacles in all different avenues to try to ensure that the knowledge is shared and not just in one pod.
I would have to agree with that. I feel, you know, collaboration is key. I have a lot of different projects going on with ECMC, Niagara Falls Memorial, working together with FQHC hospital settings to, you know, work together as one, and, you know, not siloed, not by ourselves, we're working together.
And Chantal, I'd like to say something about that too. So as wonderful as Community Health Center is with providing those services, you know, when Dr. Davis calls Megan and then Megan calls health homes, like what they can't do, that's where health homes can come in for that population, because we ask those questions about caregiver stress. That's where we start the focus of our conversation. And so sometimes when you're talking about caregiver stress and they're just detailing what goes on in their life, some of those mental health issues then do become apparent. And, the care managers will say, well, let's focus on you for a minute, and then get them to those providers such as community health center, or get them to providers geographically in their area, because that's important as well. Having things within your community that you can access. And that is why we reach out to create partnerships so that people are getting the information. We like to be the conduit of communication to make sure the providers, the hospitals, the ERs are knowing not only do health homes exist, not only do child and family exist, we have a great clinic over here, a great specialist over here, so that there's shared dialogue amongst the providers and the community.
That's fantastic. We have, and I'm going to leave this open for anyone to answer. An attendee says, I notice in conversation, persons rarely discuss or use the word poverty. Is there a reason for not using the word poverty? And I will open that up to anyone who wants to address.
That's a good question. So I don't use the word poverty for a few different reasons, because I feel that the word poverty, in my own opinion, makes me feel like, oh, look at this poor little soul.
I agree.
Right?
I agree.
And like I said, I can speak from sympathy, empathy, been there, done that, and everything else in between. And when I was technically, quote unquote, in poverty, I felt like I was impoverished. I had a great mother. I had friends. I had a great neighborhood and community. It may not have been, Orchard Park, right? Or Williamsville, where I live now, right? But it was my community. And so who is somebody else to tell me that I live in poverty? I may not have what you have, but I'm doing okay in my mind. So I personally don't use the word poverty for that particular reason. And I also think that sometimes when people use the word poverty, they place a figure pops up in people's heads. And sometimes that figure is not true. So that's why I personally don't use the word poverty.
That's fair. Thank you very much. We have a question directly for Kirsten. How can families get more information about health homes and if they qualify?
Well, you can call me and I'll tell you whatever you want to know about health homes, 388-4033. No, so health homes are starting to be more of the mainstream. Most of your insurance company knows about health homes, child and family included, have websites. And if they're part of a health home, that information will be on there. You can, if you have access to the internet, you can Google health homes and it will show you all the health homes in the area, who focuses on adults, who focuses on children. Now, this is just a very selfish plug. Just call me. I'm going to put my number in the chat and I will direct you where you need to go. If it's for your child, if it's for an adult, any way that child and family can help you, we will. So it's not just about you coming aboard what we have. We may not be the fit for you, and I'll be honest and say that, but I'm going to try to get you to where you need to go. I will make a pledge to help be the vehicle to whatever platform you need. So there's tons of information out there on health homes. You can call Child and Family about health homes. You can go to Department of Health about health homes. And if you go to Community Health Center or Buffalo, they know about health homes. So either way, with one of those outlets, you should be able to get what you need.
Fantastic. So Kirby, you can go ahead and put your contact information.
Okay. She's like already done, right? It's already there.
And when we reshare this video on our social media platforms and on YouTube, we will make sure that we link all contact information for both Child and Family and for Community Health Center of Buffalo. So you'll have the links for both of these awesome services. I'm going to close. We have one last comment. Kiana says that medical trauma starts from the patient experience, from even the person who answers the phone to schedule appointments. Absolutely. Absolutely. Any final thoughts, any closing words from any of you ladies?
Me.
Okay.
I know Dr. Davis will probably end up having the last word.
No,
I just wanted to thank my esteemed panelists for joining me. I loved how transparent you were, how open. I think that, you know, I needed to hear some things, our listeners needed to hear some things, and I think that it gives everyone the ability to look at social determinants, just health in general, from kind of a different lens, probably something they haven't heard before. I want to thank Chantel and Misty, if I don't know if they're on here, for just, you know, helping put this together. It was a wonderful opportunity for me just to be able to dialogue in this fashion. So I just want to say thank you.
Yes, thank you both for being here. Send our well wishes to Dr. Ansari. Hope she feels better soon. Thank you for all the fantastic work that you're doing in the community, especially as it relates to health equity. You guys are amazing. Thank you so much. I know this conversation has been really helpful for everyone who's had a chance to see it. So with that, thank you so much. You all have a great day.
Have a good
Thank
day.
you.
Bye.
Thank you. Bye-bye.